Hi, meet our grandma, a 76-year-old vivacious lady, fond of reading, big-time foodie, and an uncontrolled diabetic. One unfortunate day, she fell sick, having fever with pain in abdomen. She was admitted in the hospital for treatment of acute pyelonephritis. 1 week later, she complained of loss of vision in both the eyes. She presented to us 2 weeks from the onset of loss of vision with BCVA in both eyes being PR inaccurate. Her both eyes were pseudophakic, with fibrin over the IOL precluding view of the fundus in the right eye, while left eye had dense exudation in the vitreous. Her intraocular pressures were raised in both the eyes and she was in considerable pain. Our presumptive diagnosis was bilateral endogenous endophthalmitis, and owing to her morbid condition, we advised her bilateral pars plana vitrectomy in one sitting under extremely guarded visual prognosis. Expecting better prognosis in the left eye, we began PPV in the left eye to find non-viable necrotic retina after clearing of exudation. We closed the left eye after injecting silicone oil. We began the right eye by peeling the fibrinous membrane with max grip forceps, and after clearing of the vitreous exudation, thankfully, viable retina was found underneath. Some satellite colonies were found sticking to the retina, but they were left as such to avoid damaging the fragile retina. After completion of vitrectomy, fluid air exchange was done and oil was injected. Post-operatively, we couldn't salvage her left eye, but fortunately, her right eye gave her some meaningful ambulatory vision. While her life would never be the same post this catastrophe, but ambulatory vision in her right eye allows her to do her daily activities and live the remaining years of her life peacefully. Now meet our other grandma, a 79-year-old hardworking lady, full of life and an avid folklore singer. One unfortunate day, she fell sick, having fever. Few days following fever, she complained of loss of vision in both the eyes. She presented to us with loss of vision in both the eyes for 1 month, with BCVA in both the eyes being PR accurate. She was found to have bilateral vitritis with retinal detachment, with multiple atrophic holes. She had a sieve-like retina in both the eyes. Our presumptive diagnosis was bilateral ARN, and we advised her bilateral vitrectomy. Core vitrectomy in the right eye cleared the intense vitritis. Large atrophic holes were evident superotemporally, while inferior retina was found to be atrophic. Vitreous was tightly adherent to the retina, and forceps were used to complete PVD. Vitreous base shaving was completed. While trying to peel epiretinal proliferations, an inadvertent tear was formed superonasal to the disc. BBG was used to stain the ILM, but owing to the extremely fragile nature of the retina, ILM couldn't be peeled successfully. Fluid air exchange was done and silicone oil was injected. Owing to numerous breaks, 360-degree panretinal laser photocoagulation was done. The left eye had a similar picture with much larger breaks and patches of retinal atrophy. Subretinal proliferation was quite prominent temporal to the fovea. Fovea-sparing ILM peeling was done, and it was followed by silicone oil injection. It's been 3 months since surgery, and she has been doing decently well with both eyes, giving her just ambulatory vision. Long-term follow-up in such cases is critical, and prognosis is usually not very good. Her life has changed drastically post this tragedy, but her optimism helps her sail through her routine activities. While we might not have achieved best of the outcomes in these cases, but to a person in total darkness, even a glimmer of light means the world.